always difficult doing this virtually. It's never any fun to talk to a screen. And Angela Marino, hi. It's lovely to see some faces. I see Eliza's there. Wow, look at that. Okay, I'm seeing some familiar faces. It's always lovely to see people in the crowd. So I'm Dr. Trevor Janz. I've been doing this for a long time. I'm delighted to be here having this conversation with you. This is a repeat of a previous conversation, and I think that we in long-term care can do a wonderful job of relieving suffering for seniors suffering from late frailty and dementia, and especially their families. Most of these families have never had their father or mother die of Alzheimer's disease before. And many of us on this call have seen this hundreds, if not thousands of times. We've watched this movie. We're very familiar with how it goes. And we can bring a lot of comfort. We can bring a lot of relief of anxiety and apprehension. We can give them a sense of control. We can give them a sense of not being so lost and overwhelmed by their situation. If we can have conversations that orient them to the dementia journey, orient them to that dementia trajectory and where their loved one is in that journey, how we know they're at that place, and what that looks like, some of the behaviors that we're going to see, explain some of the changes that they're seeing in their loved one based on the dementia and what it's doing to them, helping them understand that it's the dementia that's causing their loved one to behave this way, and especially to help them get used to what's coming in the future. This is where we are now, is the first conversation that I want to talk to you about. And a part of that conversation is what's coming next. We're in the middle stages of dementia. Your dad is having more trouble dressing. He's starting to have troubles in the bathroom. Over this next year, I'm expecting that he's going to need more help with dressing. He's probably going to start to lose continence of first bladder and then bowel. And we may get into troubles with his walking and he may start having falls. There are a bunch of things that we can do together as a team to make this easier and to manage some of those things. And we're going to do that together. When you have a conversation like that with a family, it creates a lot of connectedness. It creates a lot of emotional trust, connectedness, that kind of thing, and helps give them a sense of control. It helps empower them, helps relieve anxiety, helps them feel more oriented. When we have these conversations, that's an essential piece of a palliative approach. So all of what we're talking about is grounded in a palliative approach in long-term care. And the truth is that none of our patients are getting better and going home. Every single one of our patients is going to die in place. And in my world, probably a quarter to a third of my admissions who come in the door die within 3 to 6 months of being admitted. And my average length of stay is about 16 months, 18 months. There are the long stayers that say 3 or 4 or 5 years, but they skew the statistics. And many people are here for a year or two, maybe 2.5 years, and then they die. So we're in the last year or two of their life. And the sooner we can start talking about with families, we're a profoundly death phobic culture. We don't want to talk about the D word. We don't want to go there. We all know the dad's dying, and we talk about that as a family. Yeah, when is dad going to die? But talking about it with the doctor or actually saying, how is it going to be when mom dies? Those are terrifying conversations, and families shy away from them. And if we, as their trusted guide, can not only be comfortable with that, but mm, relaxed and normalize this conversation for them and have the conversation about dying in early ways and bring it up in a way that helps us be hopeful for the quality of life with the time we've got left rather than pessimistic about, oh, dad is dying and everything, the sky is falling and this is terrible. We need to normalize that conversation. So the palliative approach in long-term care consists of exactly that, those comfort conversations, those conversations about comfort and quality of life, about their values, about their preferences, about their fears, about their choices. All those things are really important. So a good palliative approach involves earlier conversations, better conversations, evolving conversations, anticipatory conversations. This is what's coming. Yeah, normalizing conversations, information, and gathering information from them about their values, their preferences. A second kind of conversation I'm going to model with you, if the first one is where are we and what's coming next, the second conversation is the advanced care planning conversation, and I'm going to model one of those for you today. And the third conversation I want to model is things are changing, the end is getting close. We're getting closer to the end. I think your dad may be dying. Yeah. So in a palliative approach, better, earlier, more complete conversations, comforting conversations, a focus on comfort, not cure. Not one of the diseases that my patients have is going to be cured. I'm not curing anything. They've already got all the diseases that we've been giving them all these pills to try and prevent for years. None of them are getting better. And it's about comfort rather than cure. It's about quality of life rather than quantity of life. Good palliative care seeks neither to prolong life nor to hasten death. Our job is to improve quality for the time that you've got left. A good palliative approach takes in the whole person. It's not just the medical part, it's not just dietary, it's not just activities, it's the whole person, the psychological, the emotional, the social, the spiritual, the social work, the money and the bills and the financial piece as well. The existential piece, is my worth, is my life worth anything? Is anything that I've done going to be remembered? What legacy will I leave behind? How will I be remembered by my family? Those legacy questions are often big for people as they're dying. So focusing not just on the medical, but on all the other needs, and not just for the patient. I see my patient as the resident, but also their family unit. And when I think about the comfort that I can bring, I can bring physical comfort and emotional comfort to the resident. I can do a meticulous job of their pain and symptom management. But the biggest effect that I have, I think, is in the dynamic with families who are grieving. They're doing anticipatory grieving about losing their loved one. And there's so much suffering in that. And we can help support that in such a meaningful way. I go home at the end of the day, and if I've had a really good multidisciplinary conference with family, I had an advanced care planning conversation, and really understood their hopes and fears and helped them understand the path ahead, I feel like I've made a real difference. I feel like I've really improved their quality of life, relieved some of their fears. Yeah. So we can do a lot there. So another important pillar, if there's conversations, focus on the whole person, meticulous comfort care and pain and symptom management is another piece of really good palliative care. I have to not just wait for troubles to come, but go looking. How is their skin? Are they having pain? How is their sleep? Are their bowels working properly? Can we reduce the medications or fine tune them to the best level? What about nausea? What about nightmares? What about delusions? What about untreated depression? I need to be actively looking for trouble and paying attention when it comes. We know that people with dementia have sleep disorder and day-night reversal. We know that they have delirium. They often have delusions, psychosis, hallucinations. They often have persecutory thoughts. They often have thoughts about their end and wondering if they want to end that sooner with MAID. All of these things need exploring with them. And palliative care is not passive care, waiting for troubles to come up. Good palliative care is active care, where we go looking and examining each of these domains at the multidisciplinary conference and in routine day-to-day care to make sure that we're doing the best job that we can. And it involves the whole team. It involves pharmacy, it involves the social work, it involves the care aides and the doctors. My vision of a good palliative care team, a good long-term care team, has the resident or client right in the middle and a triangle of the nurses, the family, and the physician around that patient, all communicating with each other. And when all three parts of that triangle are connected and have a shared language, shared understanding, and shared goals about what's important for John, then we can do a really good job. But if the doctor's missing in action and you're only getting faxes and they're not darkening the door and they're not having those conversations with the family, we're really limping along. It's not going to go nearly as well. Likewise, if the family are absent, or especially if there's a daughter from somewhere far away who's not been part of the conversations and has not seen mom changing, and then she joins at the last minute as mom is dying, we've really dropped the ball there. And that's going to go badly because she hasn't been brought along on that journey of multiple conversations as their parents' illness evolves. Progressively now, especially in this last 3, 4 years since COVID, nursing missing in action has been an increasing problem in my world. Out of the 12 nursing lines in one of my buildings, 2 of them are filled by permanent staff, and the other 10 are contract nurses. And they come and they go. They come through the building, they stay for 1 to 3 months. They're sometimes green as grass and know nothing about palliative care or long-term care. And we're training them up. And just as they start to figure this out, they go away, move somewhere else. So that inconsistent care in nursing is one of the biggest challenges that I face in providing really good quality of care for residents. So it's not just the family and the doctors who can be missing in action. Sometimes it's the nursing team and lack of nursing leadership if you don't have good leadership in the building. And for those of you who are leaders in your building, let me tell you, you create the culture of care in your building. Your leadership has a profound effect on the quality of care that the residents receive. You help support healthy relationship in your staff and healthy relationship with families and healthy communication in the team. And when we as leaders promote that healthy communication, the patients and families absolutely benefit. Communication within the team, shared goals, shared language, a common approach to the patient and a common understanding of the palliative approach is a crucial piece of doing this really well. The fifth and final piece of a good palliative approach is avoiding potentially burdensome medical interventions late in the game. There's a lot of things that we can do, but probably shouldn't. For someone with very late frailty or late stage dementia, sending them to the hospital every time they have a decreased level of consciousness, or because their weight is falling, or because they're not sleeping, or because they're more confused, is usually the wrong answer. I've been an emerge doc for 30 years, and to receive a patient that I don't know with no background and no relationship to family and no idea of their baseline, and the presenting complaint is weakness or not eating or decreased level of consciousness, they're going to get the whole works. They're going to get blood cultures. They're going to get a CT scan of their brain. They're going to get the full-on workup. And I'm going to find stuff and I'm going to medicalize what's going on here when 95% of the time what's going on is that their dementia is progressing, or because of their late dementia, they're dehydrated and are showing signs of a urinary tract infection, which is really them dying of their late stage dementia because they're not drinking, or pneumonia, probably possibly because they've aspirated because they're forgetting how to swallow, again, as a consequence of their late stage dementia. And all of these things are much better managed in the facility. Yeah. When we talk in the advanced care planning, one question in the advanced care planning is trying to avoid use of the hospital. And I'll model that conversation for you. So that's all the palliative approach. And I have to point out early on, all of these conversations that we're talking about apply to the 85 or 90% of the long-term care population that it has late frailty or moderate or late stage dementia. And there's 10 or 15% of our population that is not that. They're younger, they're healthier, they're expected to live for 10, maybe 15 years. They have mental health substance use issues. They have personality problems. They have oftentimes lifetime substance use or lifetime mental health, schizophrenia, bipolar illness, personality disorder. And they're here because they can't be housed anywhere else, not because they're dying, but because they've failed in the home, they failed home care, they fired all their home care. They can't be housed anywhere else. And they're in long-term care. And these conversations are not for them because they're not dying. So that 10 to 15% are going to be more actively treated medically, and the goals of care are quite different for them. So I want to be clear that the conversations that we're talking about are palliative conversations, and they're for people with late frailty and middle to late stage dementia, not the younger, healthier ones. So I want to talk about the dementia trajectory. And you and I understand dementia as a process that unfolds over time in a fairly predictable pattern. Families don't know that. Families don't know that dementia is a terminal illness. You die of your dementia. You don't die of old age with Alzheimer's disease. You actually die of Alzheimer's disease. And with Alzheimer's disease and the other dementias at the end, you forget how to dress and you forget how to manage in the bathroom. And then you forget how to feed yourself. And then you forget how to walk. And as you're forgetting how to walk, you're forgetting how to talk. And at the very end, you forget how to swallow if you last long enough. And that trajectory needs to be explained to patients so that they understand what's going on. Alzheimer's dementia is typically a 6 to 13-year disease from the time you get diagnosed to the time that you die. And the early stages of dementia, while you're typically out in the community, in the early stages of dementia, you lose one by one all of the instrumental activities of daily living. And the easy way to remember instrumental activities of daily living is these are all the skills that my 17-year-old son needs to learn before he can go out, get his own place, and live successfully on his own. He needs to manage time. He needs to manage money. He needs to be able to get to work. He needs to be able to keep appointments and not miss them. He needs to be able to plan and execute things and do food and groceries and shopping and transportation and find his way around town. All of those are instrumental activities of daily living. And as you have early dementia, you gradually lose all of those things. You graduate from early dementia to middle stage dementia, and that early stage dementia for Alzheimer's disease is somewhere between 3 and 6 years from the time that you first show symptoms to the time when you graduate to middle stage dementia. And you know you're in middle stage dementia because you can't be left alone for even an hour by your caregiver without supervision. When your caregiver can't run out to the store and back because they don't know what you're going to get into, whether you're going to get lost, whether you're going to hurt yourself, whether you're going to wander away, then you're officially in middle stage dementia. And middle stage dementia typically lasts about 2 to 3 years. And in middle stage dementia, you fairly quickly come to long-term care. Caregivers who are really good at keeping them at home will keep them into the middle of middle stage dementia, but by the time they're up all night and managing incontinence of bowel and bladder and unsafe walking and behavioral challenges, they're totally burned out and exhausted. The people who come in too late, the families, the caregiver breaks down mentally, physically. They're in such rough shape. I have so much compassion for them. They're the people I feel most protective of when they bring their loved one in and they feel so guilty and so much a failure. We can help those family members so much by validating their experience, by saying, you deserve a medal. I can't imagine how you've managed your dear husband at home for so long. This is impossible. Our team of 8 staff who are here 24/7 are having trouble managing your husband, and you've been doing this all by yourself for the last 3 years. It's no wonder you're so exhausted. I want you to go home. I want you to rest. I want you to create a life at home where you're allowed to nourish yourself and care for yourself. Your loved one would feel terrible if they understood how hard this has been on you. They wouldn't want that for you, and they would want to be here to make it easier on you. You've absolutely made the right choice in bringing your husband here. I can't imagine how you've lasted this long. And when they hear that from someone who's got some experience, someone who's got some authority, the doctor guy with the gray hair and the stethoscope, it validates their experience and they don't feel so guilty. You can say everybody feels guilty for bringing their loved one in. Everybody feels like they don't visit enough. Everybody feels like they're not doing enough. Mary, when I see how much you've done for John, you've done so much more than anyone I can imagine. You deserve a medal, truly. You're going to get points in heaven because you've done so well for John. And you can help them with that guilt. Send them home. Say, you don't have to come every day and stay all day. Can you please stay home, take a day off? Everybody gets a day off. John's not going to mind. He doesn't even notice. He doesn't remember when you've come, when you've gone. So you might need to give them permission and help them set some boundaries for themselves because they're not going to do that themselves very well. So patients come in early to middle stages of the middle stage of dementia. In the middle stage of dementia, you gradually lose all of your basic activities of daily living. And the basic activities of daily living that you lose are in a very specific order. First, you start to have trouble with grooming. That's hair, teeth, makeup, shaving. And then you start having trouble with dressing, putting the right clothes on. People will start layering their clothing, or they'll start dressing or undressing improperly, and they need more support with that. And then they start getting into trouble in the bathroom. But first, there's urinary incontinence, a little bit of dribbling now and then. Once in a while, they're dribbling in the day. Oftentimes, they're wet at night, and then they're wet during the day, but it's just little dribbles and they can manage with a pad. And then they start soaking completely and losing their whole bladder completely, but they're very aware of it and they've got some warning and they can't just quite make it in time. And then they start having accidents with stool, and then they're incontinent of stool 50% of the time, but still being able to toilet half the time. And then they're incontinent all of the time and they can't make it in time, but they still know they need to go and we're trying to toilet them in time. And then they're completely unaware that they've been incontinent of stool and they're gradually losing their continence. Around about that time, the next thing that comes is either the walking, the talking, or the feeding. And if it's Alzheimer's disease, most people with Alzheimer's walk till the last dog dies, but they start losing their language and the sentences get shorter and shorter. And they're less and less able to understand instructions. The instructions need to get simpler and one-stage instructions instead of two or three-stage instructions. Everything gets simpler as they're gradually losing their language. A great question you can ask family is, what's the longest sentence that John can say? And those sentences will get shorter and shorter. Can John tell you what he needs? Can he say, I've got a sore elbow, or I've got a toothache, or my knee hurts? Are they still able to express their needs in words? They gradually lose all of that with their language. They lose their walking. Alzheimer's, you walk until late. Vascular dementia, you can lose your walking early in the game. You can have a stroke that takes out hemiparesis, takes out your arm and leg. Or you can lose your talking. You can have an aphasia, an expressive aphasia, I can't talk. A receptive aphasia, I don't understand what you're talking at me. I can't understand the concepts in those words. The aphasia can come, or the walking can go, or they can lose their swallowing. And in the advanced care planning conversation, we need to ask about feeding tubes, especially in these people, because they could lose their swallowing and we would have to decide whether they need a feeding tube or not. Alzheimer's, you keep walking for a long time, you lose your language, you lose your continence. Gradually, you lose your feeding and you need help with feeding, and then you lose your walking eventually. Parkinson's disease, Lewy body dementia, you lose your walking early in the game and you often lose your swallowing. They get into troubles with swallowing. They have trouble swallowing their saliva. They're choking on things. They're aspirating more and more often. And by the time you get to late stage dementia, you've lost 2 out of 3 of walking, talking, and eating. And when you're in late stage dementia, you're total care. You're not doing any of the basic activities of daily living. You lost all of those, and you're gradually losing walking, talking, and feeding in one order or another. Late stage dementia is much shorter. If the early stage is 3 to 6 years and the middle stage is 2 to 3 years, late stage dementia is 6 months to a year and a half, and you're total care and you're a mechanical lift transfer. And we judge your progress in late stage dementia by how interested you are in eating and how much of the day you're awake versus sleeping. And in the early parts of the late dementia process, you're still interested in food and you're still awake much of the day. As you get closer to the end, you're sleeping 50% of the day and then 70% of the day, and less interested in food. And then your weight starts to drop. And when you hear that people are skipping, they eat a good breakfast, but they're hardly eating any lunch and suppers come and go, and their weight is starting to drop a little bit, or they're still interested in their favorite foods that their sweetie brings, but the vegetables and the regular supper, not so much. They're hardly touching their meals anymore. That's telling you that you're getting closer to the end. And we know I tell families, we'll know we're getting closer to the end when he's less and less interested in food, when you bring him his favorite food and he takes 2 bites, but that's all he wants, and he's sleeping more and more of the day. A simple question for the care aides is, what percentage of the day is John sleeping? In the 12 hours between 7 or 8 o'clock in the morning and 7 or 8 o'clock at night, how many of those hours is he actually awake? And you work it out. Well, he's awake for maybe an hour and a half at breakfast, maybe an hour at lunch, an hour if we're lucky at supper. He's awake for 3 hours out of 12. That's 25%. That's a quarter of the time. He's sleeping 75% of the day. So I think people who are sleeping 75% a day are in the last months of their life. Maybe 6 months, maybe 3. Depends on how quickly it's changing. With all of these changes, the quicker you're changing, the quicker the next step is going to come. And if you've been at this stage for 3 or 4 months with no changes, we've got months left to go. But if you've lost your walking 6 months ago and you're losing your talking over that same 6 months, and you're less and less interested in food over the last 2 months, and you've stopped eating much for solids in the last week or two, we've got weeks left to go. And when you stop drinking liquids over the last 3 or 4 days, we've got days left to go. So we go from years to months to few months to weeks to days. As we get closer to the end, everything's happening much faster. So that's the trajectory. I would have you notice that everything in trajectory is not based on diagnosis, it's based on function. What can you do? Can you still dress? Can you still walk? Can you still talk? Can you still eat? When you're eating, can you still use a knife and fork, or are you just down to a spoon? Can you load your spoon up by yourself on a plate, or do you need a lit plate to help? Are we loading the spoon for you, but once you've got that, you can take it and you can feed yourself? Are you only able to eat finger foods? Are we feeding you and we're having to modify the textures because you're starting to choke? There's a progression that you can see, and the faster you're moving through that progression over the last 3 or 4 months, the faster the next stage is coming. The best predictor of future rate of change is how quickly things have changed in the last 3 months. Yeah. So we should start on the conversations. Let's start on the first one. Where are we now and what's coming next? We've done the multidisciplinary conference. I've introduced the conference with the goal of today's conversation is for you to get to know our team and figure out what we do, for us to get to know you, for us to clarify some medical details about John. Especially what we want to know is, what's John able to do for himself and what things are we helping him with? Is there anything that he really likes that we can make happen more often? Is there anything that he hates? Now's a good time for us to work on that. If you've got complaints about stuff that's not working, we've got all the great minds here at the table. We're going to care plan about that and figure out what works best for John. Karen here is making a care plan as we talk. We're putting together a detailed shopping list, a daily care plan of what John needs in a given day for him to flourish. And at the end of the conversation, can we take 5 or 10 minutes for a bit of a talk about the future, a crystal ball conversation? Once the care aides and stuff have gone back to work, can we take 5 or 10 minutes just to talk about the future and what may be coming and what choices might you guys make? And I warned them at the beginning that that's coming. So we've gone through the conference, we've heard everything that John does. They say, okay, I'm hearing a clear picture that John has changed quite a bit in this last 3 months. In the 3 months before he came to us, he had a serious delirium in the hospital with his bladder infection, and he had somewhat recovered from that, but he's much weaker than he was. His walking is pretty dodgy. He's walking with the four-wheel walker, but we're hearing about more falls once in a while. He's needing quite a bit of help with dressing, and we're shaving for him. He can't seem to manage that himself anymore. We're getting into trouble in the bathroom. He's incontinent of urine now and then, and we've been wearing a pull-up. His speech is less than it was before. We're wondering if we had a bit of a stroke while he was in the hospital, because he had definite difficulties with his speech and his swallowing. So we're securely in middle stage dementia at this stage. When I look at the future, I'm thinking that probably in this next 6 months, we're going to have more incontinence of urine and stool, and eventually he's going to be in a brief. I'm worried that he might fall, and a hip fracture at his stage would be very serious, and we're going to talk about that. We've talked about comfort. I want to make sure that we deal with the pain that we've heard about from changing. I'm hearing that he's got a pretty good quality of life in activities. He's really enjoying himself. If John was at the conference, I would say, John, this might be a bit of a strange question, but are you having any fun? And John will look at you and he'll say, well, yeah, actually, there's a hockey game. I got apple pie. My wife comes. Yeah. Or he might say, fun? Are you kidding? I haven't had any fun since my wife died. Or how could I have any fun when I'm locked up in a jail like this? I never wanted to be here. I never wanted to live like this. Or I can't see why I'm even here. All my friends are gone. My wife is gone. I'm just waiting to go. And the sooner it happens, the better. That's going to really color the conversation that we're going to have next about goals of care. So asking about quality of life. John, are you having any fun? Or ask the family, do you think John's having any fun? Is he enjoying himself in any way? That's going to really help us. It's going to set the tone for our conversation about what happens right now. So now we're jumping into that's the where we are and what's coming next. And then I jump right into the advanced care planning. Can we talk about some choices? This, by the way, this is, I'm not worried about John. John's doing fine, but I have to talk about some serious things. I need to talk about heart attacks and strokes and pneumonia and the ICU and ventilators and falls and hip fractures and major surgery and feeding tubes. And this is a serious conversation, but the truth is that for about 8 out of 10 people, they won't be able to speak for themselves as they're getting closer to the end. And I'm going to be looking at you, Mary, and asking what John wanted. And interestingly, Mary, by the way, Mary, I won't be asking you what you want. I'm going to be asking you, as an expert in John, what John would say if he was able to answer this question. If John's there, the first question is, John, you might not be able to speak for yourself at some point. Who would you like to speak for you? And if the more of the family that are there to hear that, this is crucial. When John says, well, I want Susan to look after the money, but I want Helen to make decisions about the medical stuff. And if he can say that to his children, you've just saved a whole bunch of heartache. When it comes from the horse's mouth, this really helps with the family, especially families that are divided, especially families where there's trauma, where there's already some conflict, where there's a lot of drama. Make sure that you get as many family members as possible together for this conversation and get John to say from the horse's mouth who he wants to be the boss. You've just saved a whole bunch of trouble. So that was the first question. Thank you, John. That was easy. The next question is about being kept alive on machines. If you had a heart attack, if your heart stopped, if your breathing stopped, if you were dying, basically, there are some people who would want us to put the paddles on them, put the paddles on, give them an electric shock, a defibrillator, to try and restart their heart. At that point, you wouldn't be breathing, and they would put a tube down your throat into your lungs, intubation, and they connect you to a ventilator, a life support machine that would breathe for you, and you'd be in a coma. There are some people who would want us to do that, and there are other people who would say, if I'm dying, don't you dare keep me alive on machines. I would never want to live like that. I want you to call my family and hold my hand and make me comfortable and let me go. What do you think, John? And John, even with middle stage dementia, can almost always answer this question. And interestingly, in the context of the larger conversation that we've had, 95% of my Johns say, I would never want to be kept alive on machines. And when they say that right in front of their family, you've just prevented a whole bunch of potentially burdensome medical interventions at the end. It's a crucial one. And very few people, I mean, once in a while somebody will say, oh yeah, why not? Give it a whirl. What have I got to lose? And then I have to explain about anoxic brain injury. And at age 84, with the circulation in your brain, as bad as it is, if you were without oxygen for a minute or two, you'd be in a coma with irreversible brain damage. And the truth is that we can't do CPR in long-term care. We don't have a defibrillator. And by the time the ambulance got here, even if they got here in 10 minutes flat, it would still be too late for you. I've never done CPR and defibrillation in long-term care in the 30 years I've been doing it. So it's not really an option. And if you were my father, I'd say, please don't do that because I don't think it's a good idea. And we come to that. And if they insist, I say, okay, sure, absolutely, if that's your choice. And we'll call the ambulance, we'll call 911, and they'll get there and say, he's been down for more than 10 minutes. We're done. They wouldn't defibrillate. They wouldn't do any of that. So it's an academic question in my patient population. So that was easy, John. The second question is a little tougher. It's about feeding tubes. If you had a big bad stroke and you were completely paralyzed over half of your body so that you couldn't walk at all, you would never walk again, and you lost your ability to speak, so you couldn't tell us what you wanted, and you lost the ability to swallow, so you couldn't eat and you couldn't drink. There are some people who would want us to stick a tube in your nose, down into your stomach, and feed you a milkshake to keep you alive, even if you were in a coma. And there are other people. And at this point, John's already interrupting me and saying, no, I'd never want that. No, never want that. John, well, wait, there are some people who would say, no, I would never want a feeding tube. Well, that will be me. I would never want a feeding tube. And again, 95% of patients say, I would never want a feeding tube. Families, not so happy about that. And they often want a feeding tube. And I say, are you sure, John? And then I look at Mary and say, Mary, how would that be for you? And Mary says, well, what if he was going to get his swallow back and it was only going to be a couple of days, you know? Sometimes you can't tell at the beginning. I say, yes, that's true. We'd keep him here. We would make him comfortable. We would know within 2 or 3 days if he was awake enough that he might benefit from hydration with an IV. And at that point, we could send him to the hospital if we thought he was recovering. But 95% of the time when you have a stroke like that and you've lost your swallow, you're unconscious. The intracranial hemorrhage is severe enough that you're probably not going to regain consciousness anyway, and you're actively dying. But yes, we could absolutely have a conversation at that point about an IV if we needed to for hydration, if he was maybe recovering. But John is telling us pretty clear. Are you sure, John? No feeding tube. Now, John's pretty clear. It might not be what you want, but it's what John wants. And families say, that's hard to hear, but it's what Dad wants and it's not about me. So that's a crucial one to have, because if we haven't had this conversation and John has his stroke, then I'm phoning Mary and saying, Mary, John's had a stroke. I've just examined him. It's pretty major. I don't even want to send him for a CT scan. This is a major intracranial hemorrhage. He's in a deep coma. I don't think he's going to survive. I think he's dying. And he's not able to eat or drink. Isn't he going to get dehydrated? Yes, but dehydration is a natural and comfortable way to die. Dehydration is nature's way of shutting down your system peacefully and quietly. You just get sleepier and sleepier and you go to sleep. You don't experience thirst. Your body just shuts down and you get sleepier and sleepier. I'm not asking you what you want. I'm asking you what John would want. And John was pretty clear that he didn't want that. If we hadn't had that conversation and Mary had to decide, she's damned if she does and damned if she doesn't. If she says, yes, let's go to hospital and put in a feeding tube, she's just sentenced her husband to 2 or 3 or more years of poor quality of life in a vegetative state, being kept alive by a feeding tube. And if she says, no, I don't want a feeding tube, then she's the woman who let her husband starve to death and die of dehydration. So she's going to hate herself no matter what she chooses. The only escape for Mary is for us to ask John and for John to say, no, I would never want that. So this is a conversation I have with everybody who comes through the door. And it's not uncommon for 3 months later for us to be in exactly that situation and for me to remind Mary, yes, we had this conversation 3 months ago. I'm sorry to say that here we are now in exactly that situation. So that's a big one, the feeding tube. The next question's a little harder, and we don't have to make a decision about it now. It's about falls and hip fractures and major surgery. I'm worried about John because his walking is not solid, and based on how quickly things have been changing, I'm worried in this next 6 months, he may be falling more. And if he fell and broke his hip at 84 years of age with his diabetes and his congestive heart failure, his survival would probably be only about 30 or 40%. There's a more than 50% chance that he would die with or without surgery in the week after his hip fracture. He was so sick in the hospital last time that we thought we were losing him then with just a bladder infection. So a hip fracture, I think, would be too much for him. We don't have to send him for surgery. We have the ability to keep him comfortable right here. We can immobilize his leg and give him pain medications and make him comfortable. And 4 out of 5 people who are as frail as John slip away peacefully and quietly in the 4 or 5 to 8 days that after the hip fracture, they die peacefully and quietly. John, do you think you would want major hip surgery? Well, I had my hip replaced 8 years ago, and that made a big difference. And I was walking within 2 months. The doctors couldn't believe how well I healed. Yes, but John, you're a lot older than you were then, and you're a lot frailer, and your heart's a lot tireder. When you were in the hospital last time, you got into real trouble with a bladder infection. Yeah. Mhm. Okay. So that's an important question. So that's major surgery. The next question is about trying to avoid the hospital. I'd love, I'm happy to tell you, Mary, that I think we do a way better job than the hospital right here at Jubilee Manor when it comes to heart attacks, strokes, pneumonia, bladder infections, skin infections, blood clots. We've got antibiotics, we've got Lasix, we've got morphine, we've got nitroglycerin, we've got oxygen. We can do a better job than the hospital, especially for John, now that he's confused and frail. Staying in a familiar environment is an important piece of this. Can we stay away from the hospital unless we really need it for something to make him comfortable? And 90% of families say, I would love that. The hospital was a disaster. He couldn't wait to get out of the hospital. It was such a bad place for him. So when John says that would be fine, that really helps us a lot. And the family say that's fine. The last question, John, it's really a philosophical question. It's about when you're actually on your deathbed, you're in the last days or week of your life. You're there on your deathbed. There are some people who would want us to do everything we could to keep them alive for as long as possible. And there are other people who say, no, when it's my time to go, don't keep me. Don't let me linger. I don't want to just lie there in the bed with no ability to do anything. When it's my time to go, let me go. I don't want to dwindle. I don't want to linger. What would you say? And I'm not asking because I really need an answer to this. I'm asking so that family can hear. Because almost universally, John will say, let me go. I've lived a good life. There's not much left for me now. My family will miss me, but I'm done. I'm ready. When my end comes, that will be a happy day. Or when my time comes, call my family. Don't let me suffer, but let me go. And I write those words in the advanced care planning on the most sheet, let me go. And I put quotation marks around it because that helps me remember that that's exactly what he said. And I can feed that back to daughter who's melting down as dad is dying and she wants him to go to the hospital. I can say, we had this conversation with John a year and a half ago. And even then he said, let me go. And when family hear that, it really helps them. Thank you, John. Thank you, Mary. This has been really helpful. I'm really positive that we can do a really good job of giving you a good quality of life. There are lots of things we can do to enjoy the abilities that you've got and to help support you as you need more help over time. Thank you so much for this conversation. It's a difficult conversation, but I'm glad we were able to do this together. And I'm going to make sure that we get what John wants. John, my goal would be for you to drive the bus for as long as you possibly can, even right to your last breath, to have it be the way you want it, right to the last breath. And what we've done with this conversation is that we've walked the family through all of the ways that John might die. We've talked about heart attacks, we've talked about stroke, we've talked about feeding tubes, we've talked about hip fractures. I might have mentioned pneumonia. And we're walking the family through the future and we're getting them ready. We're doing that death preparation thing. At an emotional level, they're getting ready to say goodbye to their loved one. And we're helping them with that process and we're framing it in positive language and we're putting a positive spin that says, and we're going to make you comfortable every step of the way. And there can be good quality of life in this. So that advanced care planning conversation creates a lot of trust, helps set a lot of clear boundaries for the rest of the family about what John wants, and helps prevent a lot of strife at the end where family, as John is dying, everybody melts down. Anytime your father is dying, people go temporarily insane. Justifiable homicide on the basis of insanity. They come apart at the edges. And the more we can do to support that process in anticipation, let them do some anticipatory grieving, they're hearing what's going to come, and their heart has time to get ready for it. So that 3 months later, as John is falling, they're ready for that. They heard that this was coming and they said, oh, yeah, here he is falling. You're right. He is headed for a wheelchair. He could break his hip. They're thinking about that. The first time I had this conversation about the hip fracture, half the family said, well, I think we'd probably try surgery. And I say, absolutely, that's fine. That's clear. That's good. And a year later, we have the conference and they say almost universally, oh, John's so much weaker now. He's so much less able than he was a year ago. I don't think we should go anywhere close to surgery. So we've gotten them ready. They've had time to think about it and they're preparing for the death process. So the last conversation I wanted to do very briefly is the end is near. And you need the care aides and the staff to warn you as soon as they start refusing meals, as soon as they're too tired to get up to the breakfast table, as soon as they're sleeping through till 11 o'clock in the morning, and then they're still not particularly hungry when you get them up, and they're too tired to be in their chair. The care aides see these changes, and if as part of the team, they're validated, encouraged, and invited to share those changes. Our doctor's day rounds starts with who's dying, who's been admitted. Is there anybody in the building who's palliative? Is there anybody who's changing? Are there any families on the roof? And who's changing? That's a really important thing to know. And the sooner you hear that news, when you phone the family and say, we're noticing that John's less and less interested in food. He's just picking at it. And we're worried. I'm wondering if we're getting closer to the end. Or you can be more dramatic about it if the changes are more dramatic. He's not eating. I'm wondering if John is getting, if your father may be dying. And I use the D word, the dying word, very consciously. As soon as I say your father may be dying, I've got their full attention. And they know exactly what I'm talking about. It's not like he's changing or things might be different. No, we're talking about dying. And that clarity is really helpful. And the sooner we have that conversation, if I've cried wolf too soon and John rallies and starts eating again and is back up at the table 3 days or 4 days later, that's a huge success for me because the family have all panicked and they rolled in and they see John and they were ready, but he didn't die. But the next time it happens, 2 weeks or 2 months or even 9 months later, they're much, much more prepared and they do the dying process much better if they've had time to get ready for it. The worst thing that can happen to a family is for a family member, for their loved one to die when they didn't see it coming and they weren't prepared and they hadn't had time to say goodbye and do that emotional work. So if we can get them to do that sooner than they need to, that's not a bad thing. I love that. And when the call comes from us, we look good. I've noticed that John's not eating as well. He's sleeping more. His weight is falling. It looks like we're right on top of John. If Mary comes and says, they're not feeding my dad, my husband, he's getting neglected. The carriers aren't even feeding him. He was in his room and I came and his brief was full of poop and he hadn't had any breakfast and it didn't look like anybody had even seen him all day long. It's easy for them to believe that we're neglecting as John is eating less and less and he's refusing food and not getting out of bed. If we tell the family that John is changing, that's way different from them complaining to us that we're neglecting. So it's way better to come from us. John's falling more and I'm worried about hip fracture. These are the things we can do to prevent that. John is starting to choke on foods. I'm worried about aspiration pneumonia because that's the other thing that happens as they're losing their swallows. They're aspirating more and coughing and chesty. Yeah. So the end is near conversation is crucial. Let's turn it over for questions.
Yes, thank you. Yeah, you're welcome to put questions in the chat or raise your hand or just go ahead and unmute.
Hmm.
Any questions for Dr. Trevor? Thank you so much for that presentation. It was, yeah, it was amazing to listen to, and I loved how you weaved the kind of pillars of palliative care and the palliative approach through kind of the three different conversations you talked about. So.
Wendy's asking about the best way to handle combativeness. 80% of resistance to care is approach. 20% is medication. So the approach, there's a good question to ask is, are there some care aides who can get him in the bathtub? Are there some care aides who can change him without him punching and hitting? And if there are care aides that can do this and other care aides who are getting a bunch of punching and hitting, okay, let's care plan together. Let's find the care aide who's got the special sauce and find out what that looks like. And usually it's in emotional approach and patience and connection. It's all about connection. And when the care aide is able to connect with the resident, then they can get away with almost anything. And when the patient feels that they're just a body in a bed and they're being treated roughly or impatiently, or that there's some attitude involved, they're going to fight back. They're going to push back. I try not to call it aggression. I call it responsive behaviors. Patients with dementia respond to the emotional cues around them. And if you've got fight energy, they're going to meet you with fight energy. So a big part of this is approach. And there are some residents who wind up with antipsychotics eventually, but a really good care plan and a really good pieces review with the whole team is one of the best ways to do this. Unrealistic expectations. There was
I also just want to note that Omala has her hand up here. Maybe Omala can go next and then we can do a question from the chat.
Hi, Trevor. Thank you so much. I really appreciated the way that you talked us through what these conversations actually look like. I'll be recommending this to a lot of people that I work with. I'm just curious. In your examples, you had John join the conference and he was able to express himself. I'm also aware that often what we see is people being admitted to long-term care when they're further along in their journey. So I'm just curious about what sort of level of function is John at in your examples and bringing him into the conversation.
if John's in early middle stage dementia and can still follow the conversation, we can try. It's so easy to talk around John and outpace him and overwhelm him with too much information too quickly. And it's so disrespectful of John to talk around him. So sometimes we'll have the we'll do the care conference, and then I'll come with Mary back to John, and we'll have that part of the conversation with John, the advanced care planning piece, in the peace and quiet of his own room with John and Susan, the daughter, and sometimes
Thank you.
social worker to make space for that. There are residents who can handle a conference and but it's easy to overwhelm them. So oftentimes the advanced care planning conversation would be in the room with John and Mary and a family member, but not with the whole team around because it's too overwhelming.
Okay, thank you so much.
Depends on their level of function. And I want it to be comfortable for them. I want this to be a positive experience where they feel respected and seen and heard, not spoken around and pushed to the side. What else was in the chat? Those of you who need to go, it's nearly 1 o'clock and you need.
Yes, let's try one more from the chat. I think there was a question, okay, yeah, from Terry about what is your experience in people with dementia asking or wanting to discuss MAID?
Not a whole bunch yet. There, there are some people who very much need to be in control in their life, and the most terrifying part about dying is the loss of control, needing to surrender and be helpless and be dependent and to let life take you and to let go of control. So for people who need to be in control, MAID is a way of staying in control right to your last breath. And there are some people who would rather die sooner than they need to so that they can keep that sense of control in their life. And that's probably based on trauma in their past and high levels of anxiety. So the rules around MAID are that as long as you can understand what it is that you're asking for and you still say yes, then you can qualify for a MAID. And we speak about 10 minutes to midnight. You can talk about MAID and talk about MAID and talk about MAID, as long as you can still understand and remember that you want MAID. If you get to a certain stage in your dementia, then you still qualify. But if we leave it too late and you no longer remember that you want MAID, and on good days you might say, yeah, I talked about MAID, but on bad days you don't remember that at all. And the provider comes to provide and you don't remember saying that and you say no, then we've left it and we've gone past midnight and Cinderella's coach has just turned into a pumpkin. So MAID, you qualify, and you can do a waiver, a time waiver that says, okay, I want MAID when I get to a certain stage, but I'm not there yet. So it's June now. Can we revisit this in September? And in September, you say, no, I'm still doing fine. Let's talk about this again in November, on November 15th. And you sign a waiver and you just keep bumping that forwards until the point where you're getting really close to not being able to say that anymore. And then the person can decide, yes, I need to do this now. You're losing enough competence that I don't know that 1 month or 3 months from now we'll still be able to do MAID. Do you want to do it now or do you want to let it go? And that's the way it's managed, if that answers your question.
Thank you. Thank you, Dr. Trevor. Great. Well, yeah, lots of comments in the chat about just gratitude for this presentation. Thank you so much, Dr. Trevor. It was, yeah, such a great narrative. Loved how you weaved practical elements about how to have that conversation really practically into those conversations. It was, yeah, really amazing to hear, and that's echoed in the chat as well. So I'm glad other people feel the same way. Anything else you wanted to add before we wrap up and let everyone go to their afternoon work?
Well, there was one thing that I forgot last time as well. When people are at the end stage of their dementia, they are not drinking nearly as much, and because they're not drinking, they're not producing urine, and they get bladder infections, or they're losing their swallow and they're choking and they're aspirating and they get pneumonia. A really good thing to tell families who want to go to the hospital and treat medically is, your mom's not dying because she's got a bladder infection. Your mom's got a bladder infection because she's dying of end stage dementia and forgetting how to drink. Your mom's not dying of pneumonia. She's dying of end stage dementia. She's got pneumonia because she's dying of her Alzheimer's disease and has forgotten how to swallow, and food's going down into her lungs now. And when you have those conversations about the dark, strongly colored urine that gets better when you push fluids, or the recurrent choking episodes with families over and over again, they see it. Mom is not drinking nearly well enough to make any urine. Mom is not swallowing safely and she's choking more and more often. You can head off you have to send mom to the hospital for her pneumonia or her bladder infection, and you can just let her die quietly of her end stage dementia in the building. So your mom's not dying of a bladder infection. She's dying because of her late stage dementia. Yeah. She's got a bladder infection because of her late stage dementia. She's killing. So that's the only other thing I would add. Okay.
Okay, great. Well, yeah, it's 1:02 p.m., so we'll wrap up from here. But thank you so much, everyone, for joining. And so grateful, Dr. Trevor, for you being here today. As I mentioned, we'll be sending an email with a summary of the session as well as a link, and then of the recording, which will be on YouTube, and that link will also be on our website about echoes, which I put in the chat as well. So yeah, take care, everyone.